Thank you, WS team for giving me this opportunity. So my topic is to discuss about recurrent and relapse disease of GTN and GCT. So I'll start with GTN, and first I'll just touch the definition. So we have recurrent disease when HCG level becomes undetectable and then it re-elevates. We'll call it resistant disease when it remains elevated despite treatment, and we'll call it primary resistance when HCG start rising after initial two courses, or it plateaus, and we'll call it acquired resistance if there is an initial response and then it becomes plateau or it rise over at least 2 weeks. So that's about the definition. And when it will recur, the median time to recurrence in this study on about 4,000 patients by Charing Cross was around 117 days, and the greatest risk of recurrence was in the first year, both for high risk as well as low risk GTN. So going from time of recurrence to just to tell, so majority will relapse within first year, and 96% will relapse within 3 years, and that's why we have the the monitoring plan as outlined here. And for high risk also, majority will relapse in 1 year and 95% will relapse in 2 years. So then why it will relapse? So what are the risk factors for relapse in a case of GTN? So in this study, they noticed that a poor prognostic metastatic disease and an inadequate initial staging and therapy, lack of adequate consolidation therapy, and prolonged intervals between cycles of chemotherapy. So these were the factors which were associated with increased risk of relapse in gestational trophoblastic disease. So, and in this study, they evaluated the factors associated with resistance to single agent methotrexate chemotherapy. Again, the factors associated were increasing FIGO score and a pathological diagnosis of choriocarcinoma, a higher pretreatment beta HCG, and presence of metastatic disease. So to summarize, what are the risk factors for a relapse in case of GTN? It would include a large initial tumor burden, a high pretreatment beta HCG, increasing FIGO score, and pathological diagnosis of choriocarcinoma if we do not give adequate consolidation therapy, if the intensity of the chemotherapy cycles is not good and patient is non-compliant. And in some study, it has been noted that a low uterine artery pulsatility index indicates high vascularity, and it indicates increased methotrexate resistance. So before going on to the management part, I would just like to touch this topic about hyperglycosylated HCG and why, and I'll tell you why it's important. So this is from the USA HCG reference survey. So what exactly is hyperglycosylated HCG? So it is a variant of regular HCG and with a double size O-linked sugar unit, and the point is that when the hyperglycosylated HCG percentage is less than 40%, then it's either quiescent GTD or a minimally invasive GTD. And why it's important is because these are they will not respond to chemotherapy. You will find a higher beta HCG value in the test, but maybe a low borderline high. You will try to treat it with chemotherapy, but because of the presence of less presence, I mean the beta HCG hyperglycosylated is less than 40%, you will not be able to get any response. So that's why they have given a definition of quiescent disease, which can be diagnosed as a plateau in total HCG concentration in women being treated for GTD for 3 months or longer, demonstrating that total HCG levels below 207, or by demonstration of absence of hyperglycosylated HCG. And similar is the minimally invasive disease. So they will not have a higher proportion of hyperglycosylated HCG. Now, we don't test for hyperglycosylated HCG. So what is important here to keep in mind is when you have a beta HCG after treatment which has plateaued at a low level, do not jump to give a second line chemotherapy immediately, because just to make beta HCG normal. Give it some time, maybe it's quiescent disease or minimally invasive disease. The patient is not symptomatic, patient does not have a high burden of radiologic disease, so we can wait, and if the beta HCG is persistently rising, then we can start second line chemotherapy. So what we will do when we have we have diagnosed relapse GTN, what we'll do now? So we'll evaluate and we'll do a proper staging CT scans, a brain MRI if required, and if we have a questionable diagnosis, PET CT scan can also help. So options for a low risk GTN will include either a second line single agent or a multi agent. Now how to decide between these two? So if the risk score has been more than 5 to 6, we all know that many will not respond to single agent methotrexate. So in those cases, if we have given methotrexate, but we have a relapse or a resistant disease, then we just go on to multi-agent therapy. If beta HCG is more than 1000 or there is a lot of disease bulk. Now, how this value comes, this beta HCG more than 1000. So in this study, which was published in ESMO Open, and what they did was, when single agent methotrexate was given and they noticed that resistance has developed, they noticed that if the beta HCG increases from less than 100 to 1000, then the chances of response to second line actinomycin D, they decreased. But keeping a threshold of less than 1000 at the time of resistance to first line single agent, and using that threshold, they noticed that 14 patients were spared from a multi-agent chemotherapy. So this is the essence of the NCCN guideline, which says that when you are treating a low risk GTN with a single agent methotrexate or maybe actinomycin D, you have a good response, then it plateaus, but the value is less than 1000, then you can use another single agent which was not used in the first line. But if you have a good response, but then it rapidly rises to more than 1000, or there has been a poor response to initial therapy, then it's better to use a multi-agent therapy rather than using an actinomycin D or methotrexate. So that's for low risk GTN when it becomes resistant or it relapses. So what for high risk GTN? Now, what are the risk factors? Again, presence of multiple metastases to sites other than lung and vagina, and inadequate first line chemotherapy, which I guess is the most important factor in our setting. So we all know about these regimens. You can use, if you have used IMACO, you can use IMA-IP. This is broadly the regimen of IMA-IP. Then there was a study that evaluated TPT, paclitaxel cisplatin alternating with paclitaxel and etoposide. So there was a decent response rate, 19% CR, 31% PR. Then this is a sample schedule of TPT. So it is a day 1, day 15 regimen, and paclicis and then paclitoposide. Then other regimens similarly on the lines of germ cell tumors of testis, ICE, BP, TIP, paclicarbo, and liposomal doxorubicin has also been used. Now the latest buzz is immunotherapy. So whether it can be used in GTN. So there is histological evidence that GTN strongly express PD-L1. And in one series, pembrolizumab was given to 4 patients with resistant GTN, and 3 out of 4 had a complete response. And all the tumors have more than 90% PD-L1 expression. So this was another study which was actually in a low risk case where a single agent methotrexate was given, and then the patients have resistant. Avelumab was used. 15 patients were treated, and 8 patients had HCG normalization after a median of 9 avelumab cycles. None subsequently relapsed, and so even in those who were avelumab resistant, HCG was normalized by using actinomycin D or a combination of surgery or chemotherapy. So this just tells that immunotherapy is active and can be used in later lines of GTN. Obviously, it will be limited by the cost. Now, so this is again NCCN guideline which says we can use PD-1, PD-L1 inhibitors, Pembro, Nivo or Avelumab, and just note this one also, capecitabine based regimen. So we have 2 patients in our clinic, both were multiply treated, had kind of limited disease, not very extensive disease, we gave them capecitabine, and both of them are now in durable remission. So this is also can be considered in later lines when you do not have a very high burden of disease. Gemcis can also be used, though I haven't used Gemcis in GTN so far. Now, can we utilize surgery in relapse-resistant GTN? Yes. Where we can use it in uterine disease, specifically when there is heavy bleeding, a large bulk of the disease in the uterus, and so it can, surgery can, what it can do is it can manage chemotherapy resistance. So we can use surgery in this kind of situation for resection of pulmonary metastasis when it will help, when there are no other systemic metastasis, and it will be better if there is only a unilateral solitary nodule, no uterine involvement, and serum beta SH is less than 1500. So better to do a PET CT and rule out other sites of metastasis. In brain metastasis, you can use, it can be life-saving, craniotomy can be life-saving for drug-resistant lesions which are peripheral and solitary. And then you can use either SRT or WBRT as an adjunct. So whether stem cell transplantation has any role, not clearly defined. The use is limited to case reports or small case series only, and it has variable success. So in this one large study, 32 patients were treated between 1994 and 2015, and a sustained complete response was seen in 7 patients. But it was noticed that HCG of more than 12, just more than 12, and a FIGO stage 2 to 4 and presence of METs at the time of diagnosis were significantly associated with adverse OS. So I am not sure how much is the clinical utility of stem cell transplantation in GTN. So now just moving on to relapsed GCT. I'll be just touching only the salient features. Again, the majority will relapse in the first 2 years. And what are the factors with relapse? This MITO 9 study, they evaluated the factors for relapse in germ cell tumor of ovaries, and they found out that recurrence rate was 17.8%, and only 2 factors, age more than 45 years and treatment outside a referral MITO center, were associated with were the main predictors of recurrence. And I think in our setting it would be inadequate treatment and heavy burden of disease at the baseline. That would be the most important factors that will predict a relapse in ovarian GCT. So how to approach them? If the patients have been chemo naive, that means if they have been treated only with surgery in the first line and no adjuvant chemotherapy was given, and if the disease is resectable, offer secondary surgery and then followed by BEP, adjuvant chemotherapy in the form of BEP. And if it has relapsed after chemotherapy and if chemosensitive disease, just offer a platinum-based therapy. In chemo-refractory disease, again it will be on the lines of testicular cancers. So what are the chemotherapy options? Again, the same options, we all know about them. TIP we can use, where paclitaxel is 24-hour infusion on day 1, and day 2 to day 5 is cisplatin and ifosfamide. And then we can use a combination of vinblastine, ifosfamide and cisplatin, a VIP regimen. And in platinum refractory patients, we can use a combination of gem oxali, pacli, gem pacli, or all the 3. So whether we can use surgery here? Again, yes, we can use, and this Chinese study evaluated where surgery would be helpful. They did a secondary surgery in 34 patients and found out that if the surgery, if the result of surgery was a macroscopically disease-free or a residual disease less than 1 centimeter, then the 5-year survival was approximately 60.95%. And surgery was more helpful in patients of immature teratoma, and so they say that optimal cytoreduction during salvage surgery does benefit chemorefractory patients. Now this is another study which evaluated salvage surgery for chemorefractory ovarian germ cell tumors, and they noticed that survival of patients with immature teratoma who underwent salvage surgery was significantly better than other groups. So there are cases where you can offer surgery, specifically immature teratoma, and obviously growing teratoma syndrome, it will not respond to chemotherapy. You have to operate it if it's causing any symptoms. So there is limited data for surgery, but there is possible benefit, especially in patients with resectable disease. Now again, the immunotherapy buzz, has it been used in germ cell tumors? Yes, it has been tried. In this study, The platinum refractory germ cell cancer, those who relapse after stem cell transplantation, in fact, 7 patients were treated with Nivo or Pembro and 3 patients received treatment for at least 6 months, and the long-term tumor response was achieved in 2 of the 3 patients, both of them highly positive for PD-L1 staining. So in relapse refractory disease, you can consider immunotherapy in germ cell tumors. Now, any role of stem cell transplantation? This was one study, and so this is my last slide. And in this, 3 patients of ovarian germ cell tumors were there, and the stem cell transplantation was found to be beneficial even in 1 patient with platinum refractory tumor. So, of course, data is limited, but it can be considered. So, to conclude, relapsed germ cell tumors can be difficult to treat, but long-term favorable outcomes can be seen with chemosensitive disease. Surgery should be considered in carefully selected patients, especially where it is resectable disease and you can achieve a R0 resection. And stem cell transplantation and immunotherapy may be an option in multiply relapsed patients. Thank you.